Welcome to A Window on SAHMRI, where we take you inside South Australia's independent not-for-profit health and medical research institute. Each episode, we get to know the people driving our life-changing research, getting into what motivates them personally and how their work is delivering a brighter, healthier future for all.
Peter, are you one of those people who's always known what you wanted to do?
Far from it, Callum, far from it. I, as probably recently as grade 11 or 12 at school, I still thought I was going to do law or politics. I had a fantastic role model in my dad, who was a solo GP in Adelaide for 50 years. And deep down, I probably knew I was going to follow a career in health and ultimately medicine. But it felt like a late-minute decision to do medicine, to become a doctor. And then in terms of pursuing a career in cardiology, that was also very late. I got all the way through medical school, very little exposure to cardiology as a medical student. If you look at my 6th year medical school yearbook and you look at the things that I had thought or projected I was going to do, cardiology did not appear. I was going to be an oncologist or a neurosurgeon or a paediatrician. Cardiology wasn't in the equation. But I chose cardiology as my first ever rotation when I did internship, my first year of working as a doctor. And I did that because I thought I needed to know about the heart, because, you know, when patients on wards have heart attacks or heart complications, you've got to know what to do. And on my very first day of internship, when I walked into the cardiology ward, the head of cardiology, a guy called Leo Ma, asked me if it was a forebear of what I wanted to do. And I hadn't even thought about it up until that stage. I loved it, never looked back. Right up until finishing my training in cardiology, which was 2005, I finished what we call my registrar years. I had very little intention to be a researcher. And somewhat infamously, when I interviewed in 2002 to do cardiology training, I was asked by this big room of cardiologists in our department whether I wanted to do research. And I believe I was the only ever candidate who said no. I said, look, I'm just here because I enjoy the medicine. I enjoy the clinical fulfillment of treating patients. I might do the odd research project, but I couldn't see myself being a researcher. And then the next interviewer said, are you trying to tell me that you don't want to be a professor? And I said, well, it's not really on the agenda. My colleagues still remind me 20 years later of that response, because I've obviously devoted, you know, the last 18, 20 years of my career to marrying research with clinical medicine. So that's a long-winded answer to your question of did I always know what I was going to do? Far from it.
The interviewers thought that was some reverse psychology or something going on.
I think so. They thought I was probably cleverer than I really was. I was just being honest. So I think what I will say is that I'm someone who gets interested in things quite quickly. I've always thought, you know, intelligence is not about being interesting as much as being interested. You know, you absorb the opportunities around you, you're stimulated by them, whatever it is in life. And for that reason, I find that doors open all the time. And sometimes you go through a door and you say, no, I'm going to close that one. I'm no longer interested in that. But often, you know, if you open enough doors, you'll lead into some really cool directions. And the same probably applies to my research career. I was initially going to do a project when I finished my cardiology training at the end of 2005. I did decide to do a PhD, and the original project I was going to do was on a completely different topic to what I ultimately followed. I was going to do a clinical-based PhD, what would have been a fairly simple project. And one morning I was having a shower contemplating my next 3 years of PhD research, and I thought, you know, if I do that, it won't be that interesting. So I went back to my would-be supervisor and I said, hey, how about we do stem cells? Something that at the time was really cutting edge, new. I actually knew very little about it, but I just knew that it was going to be, you know, something of the future. And I got into, you know, with that one suggestion, I got into a stem cell-based PhD program. And then that led on to other opportunities overseas. And then those opportunities created new pathways of research programs that I've brought back to Adelaide. So when I look back on my career and I think, how did I get here? It's actually a very convoluted, circuitous path, but one I'm really grateful for.
It all started in the shower. Is that a regular place of contemplation?
That and the gym, that and exercise. You know, I find just the opportunity to clear your mind and to reflect on the decisions you've made. You know, plan your day. I spent a lot of time thinking. I'm a notorious pacer. Anyone who walks past my office at SAHMRI will tell you that when I'm in probably my deepest moments of concentration is when I'm pacing around the office, really just trying to get the neurons ticking over. So yes, I do a lot of thinking before I do.
Like a lion in the zoo.
Something like that.
What is it about cardiology that's captured you so much?
Yeah, so look, I think initially what it was probably the enjoyment of the medicine itself, the clinical aspect, the interaction with patients. I was really drawn to it because of first of all, the enormity of the problem that patients with heart disease have. It's extremely common, heart disease. It affects young people, but clearly it's also a disease of getting older. And the reality is that for all that we've done in the field, it remains the biggest killer globally and still the biggest killer of men in Australia. So, I felt that going into cardiology would enable me to make an impact in terms of helping people who were dealing with very serious health conditions. I was inspired by the people I was interacting with early in my training as a doctor, the doctors, but also the nurses. I learned a lot from nurses on those early months working as an intern on cardiology. And I thought, this is an area of medicine that is interesting. I can see the fulfillment and the gratification of helping people in need, desperate need, coming in really on death's door with heart attacks and other heart problems and treating them and seeing a result from the treatment that we give, quite different to other fields of medicine. Ironically, the other field that I would have gone into if it wasn't for cardiology is neurology, because I was fascinated about how the brain works. But the dilemma with neurology is you spend a lot of time making diagnoses, but when I was training, treatments were not that available. So there was a real frustration there, whereas in cardiology, treatments were rapidly evolving. And then when I got into research, I realised that for a field which is so well researched and arguably the best evidence-based field in medicine, the field with which we have the greatest amount of data to really direct our practice, despite this, there's still so much we don't know. And in the area that I study and that I treat patients with clinically what we call atherosclerotic heart disease, which is the disease is caused by narrowings and blockages of arteries in the body, including the heart. I tell my patients, I tell my students, when I give talks, I say we know the A to F of why people get atherosclerotic heart disease. It's the traditional risk factors: diabetes, smoking, blood pressure, cholesterol, genetics. There's still a G to Z that we have no idea about. And that's the attraction from a researcher's perspective. There's so much more that we can discover to create new treatment opportunities to transform a condition which is still prevalent and which still carries enormous burden.
How has our understanding of heart disease developed since you've been in the game? Was it already A to F and it's still A to F?
I think it was A to F, but we've certainly, one of the areas that I'm most interested in is inflammation, both inflammation that occurs systemically, meaning throughout the body, that then leads to worse diseases in an organ like the heart, but also inflammation within the heart arteries. And the inflammatory field over the last 20 years has evolved very, very greatly. And what's exciting now is that we're on the cusp of new treatments for various aspects of heart disease, including inflammation, that I think will get us better results. We have a field in cardiology that has already got wonderful treatments that deal with about 80 to 90% of the problem. It's us trying to address the other 10 to 20% with effectiveness, being able to choose the right patients for the right treatments, being able to initiate treatments in a cost-effective way earlier. The part of cardiology that we still don't have right is prevention. And a lot of that is still around the idea of community awareness and people understanding their risk. I treat a lot of patients, obviously, with heart attacks and very bad blocked heart arteries. And the average age when someone has a heart attack is about 62. But there are a lot of people who have heart disease in their 30s, 40s, 50s. And it's always a missed opportunity when you see that individual in front of you if you don't engage them about the good that you can do for their relatives, because family history is still very underestimated. There's so much we can do in a preventative sense if we identify people at risk because of their family history, and that's just a huge missed opportunity. I think we're better than most specialties and fields of medicine in terms of communicating to the public about heart health and heart awareness. But despite that, we still see crazy cases where people ignored their symptoms or they didn't get checked out. The number of times I'm called in to treat a person having a heart attack and they tell you that they've had pain for 3 days that they ignored, or they had a really bad episode of pain a week ago and didn't tell anyone about it. And you just shake your head and you say, we still haven't got that message through.
But it's not always people who appear to be in bad health as well, is it? Because I think that's the stereotype. It's someone who's very overweight, who doesn't look after themselves at all.
Spot on.
But I mean, I remember seeing someone at the market a few months ago who hadn't been there, one of the vendors, he hadn't been there for a few months. And he said, I had a massive heart attack. And he was a guy in his 40s in fairly good shape. And he was just talking about how he was totally shocked because he had no idea. And then he went and did the test and realised that he had those indicators, but otherwise he was fit and healthy.
Exactly right, Callum. So it's the unpredictability. I often talk about the risk factor that we haven't got a handle on, and that is bad luck. You can do all of the right things, but probably by virtue of your genetics, what I call your constitutional makeup, the way that you're packaged together, sometimes bad things will still happen. And in cardiology, as in other fields, we still don't understand the why that happens or what we can do about it. What we've learned, and actually Australian research owes a lot to this, and we're doing some work in this space, is that about 10 to 15% of people who have heart attacks will not have modifiable risk factors identified or identifiable when they have a heart attack. So they won't have a high cholesterol, they won't have had a history of smoking, blood pressure or diabetes, they might not be overweight. And then it's trying to understand why did those 10 to 15% have those events.
Will they have that family history?
Often, but not always. Sometimes they might be the first person in their family to declare themselves as having the predisposition. And then the other challenge for us is that when we treat a patient with a heart attack, for all of the treatments we currently have, conservatively at least 1 in 5 people will go on to have another event, another heart attack, stroke, or die from it within 3 years. And that's despite all the treatments that are evidence-based that we're prescribing. So the question is, how do we predict which person in that 5 is going to go on to have further problems to prevent them? And a lot of the research that I do is actually targeting the ability to predict risk both before the heart attack happens, but also after it's happened to prevent it happening again.
What's your ability to be able to assess that 1 in 5 after they have that second event and actually point to why that happened?
It's reasonable based on traditional risk factors. So I know that if I can get someone's cholesterol down to a particularly low level, that reduces risk substantially. I have ways of measuring inflammation to make sure that that's not an ongoing risk. Diabetes treatments and control are getting better with respect to preventing heart disease. But there are still other things that we don't understand. And a lot of the program of research that I'm involved with now is trying to find other risk predictors. The other thing that we're trying to, that I feel quite strongly about is that unlike my cancer specialist colleagues, we don't track disease. So if someone has a diagnosis of cancer, their specialist will usually continue to use imaging, CT or CAT scans, for example, to track how that disease responds to treatment. Cardiologists, for some strange reason, don't do that with the plaque in arteries. We diagnose the plaque, we stent or bypass, and then we rely on the patient coming back, telling us how they feel or measuring blood tests to look at their cholesterol or to check their blood pressure, as opposed to imaging the plaque to see if it's changing over time. And one of the really exciting studies that we're doing at SAHMRI through the photon counting CT scanner we have there is actually about imaging residual or remaining plaque after a heart attack. And we've got great feedback from our patients saying, a year after my heart attack, it was great to know that the plaque had actually regressed or got smaller or it hadn't grown. Therefore, the treatments that you're using are working. Conversely, our results are showing that up to 40% of people, despite seemingly having good control of their risk factors, still have their plaques progress. And we don't currently have a paradigm of treatment in my field where we go imaging disease at intervals to see what's happening. And that's something I'm keen to change.
But that technology is there now.
It's there now.
And before it wasn't, obviously.
Not to the extent it is now. So we're blessed with the scanner we have at SAHMRI. It's a photon counter, which in brief means it's got a level of resolution we haven't been used to for lower the radiation. And I think that creates an opportunity to be able to image with a greater level of confidence. We now need to do the clinical studies to show that taking that approach, a more of an active monitoring approach, can actually influence treatment. Maybe it makes patients more inclined to comply or adhere to their treatment, because non-adherence, particularly for cholesterol, is a massive problem. If you show patients, look, you've got plaque and the plaque's still growing, naturally they should be more motivated to take the treatments that you're prescribing. But imaging and monitoring also gives us an opportunity to say, geez, I thought I was doing the right thing, but I'm not controlling this disease. What else do I have to do? And we're looking at the questions of why does disease progress in some people and in other people it doesn't.
Makes a big difference to be able to put your finger on it and show it to the patient.
Big difference.
And say either you haven't been following what you need to be following, or it's not working for whatever reason, and then you have to try to work that out. But previously, not actually being able to point to those images and just say, look, I think this is happening based on your symptoms and how you're feeling, but we can't know without going back in there.
And I think what makes heart disease so difficult to manage is that people think when they've had a stent or a bypass that the problem is solved. The plaques that narrowed the artery actually take years, if not decades, to form. And so this has often been going on from late 20s, early 30s. A person has their event at 50 to 60, you put in a stent, they think it's over. But you're then trying to protect them from another 30 years from it happening again. And you're talking to them about their blood pressure or their cholesterol or their sugar, and they tell you, well, I don't feel my blood pressure. I don't feel anything when my cholesterol is high. And they therefore assume that they can come off medication, or that it's not critical that they treat those risk factors, whereas it is. And cholesterol, which is one of the areas that I particularly focus on both in my clinical life, but my research, is notoriously difficult to explain to patients, because we have all these myths that are propagated in the community through people talking to each other, through bad news stories that are unnecessarily.
What sort of myths?
Well, the statin myth. There was an infamous program on the Catalyst show about 10 years ago. I was working in Melbourne at the time, where the reporter really focused on basically suggesting that cholesterol was overplayed in the cardiovascular community, and that treating it with drugs like statins, which are the cornerstone, one of the most commonly prescribed and best evidence-based treatments we have, that statins were doing harm. Now, statins shouldn't be used in the drinking water, but when people have heart disease and they have plaques in their arteries, they are one of the most crucial weapons we have to fight it. I was working in Melbourne at the time, and I remember just a host of patients coming in threatening to take themselves off their medications because of this one story. And there'd been a whole lot of, follow-on media stories around that. And so we spent a lot of our time when we're consulting debunking those myths and trying to explain why after 40 years of building evidence, we rely on these treatments so heavily to prevent the commonest cause of death in Australia and around the world.
So my dad's got heart disease. He's one of your patients. As a 31-year-old, what should I be doing heart-wise?
Yeah, I think the most important thing is to know your risk factors, as early as you can in adulthood. So to, first of all, understand what a healthy diet and lifestyle constitutes, and that is around making healthy food choices, but also having a healthy pattern of exercise. And I'm not necessarily talking about being a marathon runner here. We know that moderate intensity exercise, 30 to 45 minutes of walking, for instance, at least 5 days of the week, is great for all aspects of health, particularly heart health. Knowing what your cholesterol is. So cholesterol, unlike what most people think, about 80% of your cholesterol is determined by your makeup, not by what you're eating. Your liver is the organ that makes cholesterol and gets rid of it. And your cholesterol level is essentially determined by the time you've gone through your growth spurts. And so understanding as early as your late teens, early 20s, whether you have a high cholesterol level, whether it's high enough that you should be taking medication. Some people have got a strong family history where a relative, typically a parent, brother or sister, has had a heart attack before the age of 55 or needed stents or bypass or had a stroke. That individual we treat as being a cardiovascular equivalent patient. So we would put them on cholesterol-lowering medicine, for instance, from early adulthood.
Would those scans be available to someone as a precautionary measure, like someone who's a lot younger, who has it in their family? Could they get a scan to see if they've got plaque build up in their heart?
So in theory, yes, but there are caveats around the way we can use the scans at the moment. So the scan that your GP can arrange is something called a calcium score, which is a very quick CT scan that gives you a number which tells us a surrogate measure for how much plaque's built up. The caveat of calcium scores is, one, it's not Medicare rebatable, so it's a several $100 expense out of pocket. And two, under the age of 50, it can be unreliable because plaque might not have been there long enough to actually calcify, so you can't actually detect it with a calcium score.
So know your cholesterol levels and those lifestyle factors.
Know what your blood pressure's like, know whether you're at risk of what we call metabolic disease, which is that combination of risk factors, a lot of which comes down to carrying excess fat around your belly and so forth. We know that up to 2/3 of people in Australia and around the world will now be overweight or obese, so understand what that's doing to your risk, not just of heart disease, but of liver and kidney disease. So know your risk factors, healthy lifestyle, incorporating exercise, good diet, and then obviously the balance of work-life so that your stress levels are manageable. Having a great regular GP. One of the challenges in primary care, general practice world at the moment, it's very hard to get into a regular GP. Anyone who goes to GPs would know you often see a different GP. It's hard to book into. So try to find a GP that you've got a good relationship with. See your GP regularly to have checkups, and then as you move through your 30s, 40s, 50s, your attention to risk factors becomes even sharper. The other thing for women, in our field, we've notoriously underestimated the impact of heart disease in women, and as a result, women unfortunately are underdiagnosed and undertreated, despite heart disease being now second to dementia, but previously the leading cause of death in women. Women have some quite specific risk factors for heart disease around pregnancy complications. So if a lady has gone through pregnancy-related complications, small babies, diabetes, blood pressure in pregnancy, their longer-term risk of heart disease increases. If a woman's gone through early or very early menopause, her risk increases. So we're now starting to recognise that women do require a more nuanced approach to risk management. And clearly in Australia, we have certain groups that unfortunately have disparity in terms of their heart risk. So First Nations people have very accelerated heart disease, at least a decade earlier in terms of when they present. And then groups that are in lower socioeconomic bands, rural, remote areas are also at high risk. So understand kind of the nuances to your individual risk profile and then work with your doctors to address that.
GLP-1 drugs have become a big part of this equation, originally for diabetes, but relevant to heart health and also obesity, obviously, which is what they've become famous off the back of. Just describe the impact that those drugs are having in your work and for your patients.
They're having a big impact. They'll have an even bigger impact going forward. So they have changed the paradigm of, first of all, how we manage diabetes. Diabetes is fascinating. We've known for a very long time that it's a risk factor for cardiovascular and vascular disease, heart attacks, strokes, etc. But ironically, despite knowing that high sugar levels were a problem, the treatments we were using for the previous 30 years to lower sugar were not actually making a dent into heart attacks and strokes. Metformin, drug called gliclazide, insulin, they weren't actually reducing cardiovascular events. And then in the last decade, two different classes of drugs, one of which are the GLP-1 receptor agonists, another class, the SGLT2 inhibitors, they flipped the script because they were actually shown to reduce cardiovascular events, heart attacks, heart failure, and other heart-related outcomes. So that was a game changer. Then when we learnt that the effects of GLP-1 extended to non-diabetes related overweight and obesity, so people were losing weight, and then we're able to show that through that weight loss, but probably also through other mechanisms, these GLP-1 receptor agonists were reducing mortality. They were reducing cardiovascular events. Last year, we learned how they reduced sleep apnea, fatty liver disease, kidney disease. It's a game changer. So as a cardiologist who would have probably up until 2-3 years ago focused on talking to my patients about cholesterol, blood pressure, diabetes, smoking, I can now have a proper, meaningful conversation about weight management. Now, everyone starts the weight conversation understandably around diet and lifestyle. But about 90% of people will not be able to maintain weight loss just with lifestyle measures. And that even applies to clinical trials where people are incredibly well monitored. We still can't get significant weight loss sustained. Anyone who's tried to lose weight will tell you they'll lose weight okay, but then after a period of time, it comes back up. I've got years and years of following the same patients. Weight comes down, goes back up. These GLP-1 receptor agonists are not only very effective for weight loss, but where patients continue them for maintaining weight loss, and then their benefits also seem to extend just beyond weight. So
and helps patients adjust their lifestyle.
Correct. So they can exercise more. They do start to, because it affects appetite and one's perception even of food choices, better habits potentially form. The key is maintaining those habits if you come off the medication. And one of the challenges we'll have there'll be a few challenges with GLP-1s. First is we don't yet have the length of follow-up data to know what the very long-term consequences are. I think there'll be good consequences. I think if we deal with weight better through the early and middle years of life, we will see less dementia, for example. I think we'll see less cancer. We'll see obviously less cardiovascular disease, but there are other long-term consequences that we have to study over many years. What does muscle mass look like? Bone density look like after you've been on these drugs for 10 years? But the other two challenges at the moment is that because so many people would potentially be eligible, how can we afford these drugs? And access within this country for non-diabetes indications, i.e. weight, at the moment is on a private script, which means patients have to pay out of pocket. And when you've got a treatment that needs to be taken for a long time, that becomes, for many, prohibitively expensive. So that's an issue for us.
And the likelihood of them being on the PBS for obesity soon?
I think we've got a challenge to convince government officials that obesity and overweight is a medical problem and it's not just a behavioural choice or a behavioural issue. I think there are some people who still, in my opinion, erroneously think it's all around poor lifestyle choices. I don't think that's always or even often the case. So I think we've got to actually, and I'm not specifically an obesity specialist, my obesity colleagues might think differently, but I think we have to get the narrative around overweight obesity right. I think it's one of the greatest challenges health faces at the moment. Once we get the understanding of what causes it and the challenges of just managing it with behaviour right, then I think we can have a proper mature conversation around the drug options, the surgical options, and then hopefully reimburse them in a way that those options are available, to a wider cohort of people.
And as you just said, 90% of patients struggle to actually keep that weight off and yo-yo up and down and have a tough time with it. So that's a comprehensively large amount of people, isn't it?
It's a huge amount.
To just say, oh, well, all those people are lazy, or that could be avoidable. It's like, well, you don't get statistics like that if that's the case.
No, Callum, and we know, we talk somewhat flippantly around the exposure that young people, kids are having now to all that screen time and spending less time on sports fields, for example. So we know that the overweight, obese, inactivity story is becoming so much stronger in our young. You think about the epigenetic changes that happen to the body, with early exposure, even exposure in sort of development during pregnancy. If your parents are overweight and obese, what's that doing to your genetic makeup to avoid obesity, when you're a kid, when you're growing? And so we have a huge challenge to manage obesity, not just in adults to reverse it, but to prevent it in our young. There's a lot of work to do in that space.
And do you think that's going to be a big part of curing heart disease?
I think it'll help. I do think this is a game changer for us because we've got a risk factor that we knew about, but we couldn't really do that much about before. Whereas I think now we can have much more pragmatic conversations. Doesn't mean that everyone should or will be on these medications, but at least we talk about the options. I don't consult now without talking about strategies for overweight obesity if it's applicable to the patient. I can honestly say 3 years ago, I might have had a brief tokenistic discussion about the need to watch what you eat or to exercise more without going into the detail I can now. So I think managing it will become easier. I think our challenge will be knowing when and in whom to use the medicines and when not to. But it's great to have more weapons. We've got better weapons for obesity. We've got better weapons for diabetes, better weapons for cholesterol, have weapons for inflammation. My field is It's always been ahead, in my opinion, of other fields when it's come to treatment options. We're moving at light year speed at the moment in terms of the treatments that are coming. Fantastic.
Very encouraging, and it makes patients feel empowered as well, rather than just telling them, well, you should be mindful of this and that and go and eat better and exercise more, to be able to say, well, in your case, we could try this. Like I think you said, it's a weapon.
Patients want options, and what our job as clinicians is to actually educate patients about what their options are, which options might be best suited to them. Patients always ask, is this treatment going to be for life? And the way I answer that is to say, well, we're going to need to get your cholesterol down or manage your weight or manage your diabetes indefinitely. But how we do that might have some flexibility. And we can try certain things, and if they don't work or they don't agree with you, it doesn't mean that we give up. We look at the next option. And now we have so many more options that, getting back to the statin story, the reality is that if a person truly can't tolerate statins, I now have other medicines available that I can use as second or third line. I couldn't do that 5 or 6 years ago.
I see you at the gym a lot of mornings. Is this a big part of why you prioritize your own fitness, practicing what you preach?
I'd love to say it's the primary. I think the primary reason for me is actually probably more mental health. Striving for a balance in what I do. I wear a lot of hats, Callum. I'm obviously a clinician. I'm the guy at 3 a.m. that's called to stent patients when they're having heart attacks. I obviously have leadership and admin roles, and I'm very passionate about my research roles. So juggling all of that requires—
And you're a dad.
And I'm a dad of 4. So juggling that requires that I find balance outside. I've found, and I've been, exercising since I was a teenager. Going to the gym, mainly resistance training, has been a big part of that. For me, it's around the mental well-being. If I don't do that, I actually find myself feeling miserable and not being as functional in the other things. So I have a perfectionistic character, rightly or wrongly, and I probably, not unlike yourself, probably am quite obsessive about the way I approach my gym work. I plan my sessions out probably 2-3 days in advance, and if I don't hit them, I'm disappointed in myself. So that just is, it's motivating for me to do it.
But that allows you to do more and be more. And people often say, I don't have time. But if you make time, it actually empowers you, it gives you, energizes you to be able to do the rest of your life.
So as you know, it means being prepared to wake up at 6 a.m. on a Saturday and a Sunday and being there at 7:30 for a couple of hours. It's a great way to start the day. And I've got, as I said, 4 children. 3 of them are now, they're all at university, so they're at an age where they're getting involved, and it's great to be able to help them through their fitness journey and try to impart some of the things I've learned. I've often said, I wish I knew when I was 20 what I know about, fitness training now. I'd be much more advanced than I am.
Well, you look in pretty good shape for your age, mate. Being a father, also growing your career, how have you managed to balance those two things? Because like I said, 4 kids, they're in uni now. They weren't before, and you were building the career that you've built. So how have you done both?
So I don't think I've always got that part of it right. First of all, I'm blessed in the support people I have in my life. So I had fantastic parents as role models who instilled in me a set of values and I guess work ethic that I have always held on to. I found a wonderful life partner in my wife, Maria, who is very much the cornerstone of our home. She made a choice to give up her career as a scientist back in the day to be there for our kids and to raise them. And that has, the reality is that's enabled me to be more aggressive in the way that I've pursued my career. Balancing clinical work and research, it does mean that there are weeks where I feel like I'm working 24/7. The most challenging years for me were when I was actually building my research career. So during my PhD and my postdoctoral research when I was in America at the Mayo Clinic and then in Melbourne at Monash. My 3 oldest children were young at that time. They were primary school age. And although I've always been the sort of dad who was there physically, I devote most of my other time to my family. But I realize in retrospect that sometimes mentally, even when you're there physically, mentally, I was thinking about the paper I was writing or the talk I had to give or the next experiment I had to do. And I now look back and I just wish I was perhaps a little bit more mature during those years, and probably realised that I was missing out on perhaps being mentally there for my kid, my three oldest kids when they were younger. I think.
Could you have done it any differently?
Oh, look, if I'd cut back on how seriously I took perhaps some of the research. I think when I got into research, the thing about research, Callum, that's quite different from clinic, at least for me. Clinical medicine, I was trained to be a clinician. I did medicine as a university student, and so it always felt like it came very naturally for me. When I clocked off at the end of the day, I always had colleagues to take over from me. I might have thought about the patients I was treating, but we're part of a team and you hand it over. When I started my research journey, research is very personal. Sometimes it feels it's you against the truth, right? Whatever it is that you're studying or investigating, you get rejections, whether it be grants, whether it get papers, you take that very personally. And so you strive harder and harder. And it took me a long time to just realize that was the reality of it. And sometimes you can't control things. And I think I probably spent, maybe from 30 to 40 when I was building my research career, worrying too much about the next research output. And it probably wasn't until the last few years that I just recognized that, that I work hard, I have a good hypothesis, I do the right thing and trying to follow that hypothesis. If things don't work out the way I expected, it's actually not my fault. And I might not have been able to do any better. And I think it's probably coming to that acceptance, which for me was just getting older and getting wiser. That's the gift of
hindsight though, isn't it? Because you've had those years to stack up that evidence and all those times it did or didn't work out. And when you're trying to make it in such a brutal industry where I very much understand that mentality for early and mid-career researchers where they do have a 6 months or a year guaranteed of their job left and they do need that next grant to come off. Yeah, it would take a lot of experience to get to a point where you realise it's going to be okay.
Yeah. So my fourth is 9. My oldest is 22. So I'd like to think that I've become a wiser parent. The older I've got a great relationship with my kids, and I'd like to think that they all think I've been a good dad. But like most things, I think hindsight tells me I could have done things a little differently.
And would you say your dedication to the Port Adelaide Football Club is a net positive or a net negative for your health?
I think it's probably a net negative. That I was blessed to grow up, in the 80s when my team was winning regularly. And it was the best part of my childhood. My dad would take me to South Australian suburban grounds, if not every weekend, every second weekend. People who played footy with me would tell you that I suffered from significant white line fever. I went from being a Dr. Jekyll to a Mr. Hyde on the footy field, and mine was always the voice you could hear probably on the other side of the oval. So I had a very passionate approach to playing the game, and I supported like that. And I was the sort of supporter that if my team lost, my week was ruined. Fortunately, I've matured a little bit in that regard, so I don't quite hold on to Port Adelaide's AFL results quite as intensely as I did when I was a kid. But it's great for me, Callum. It's my outlet for 3 hours a week. I watch almost every game. I think I might have missed one or two, maybe the day I got married.
Turned a few off, maybe.
Turned a few off. I've probably turned a few off, but I set my clock to watching the Port games. As I've told you, if I'm not at the ground, I would tend to mute the volume on the TV and I'll watch. I may or may not pace during it. And then when the game's over, I'm able to bounce back pretty quickly, win or lose.
When you love a team, it's not exactly the most pleasurable experience sometimes, is it, when your heart's all the way in it?
Sometimes you wonder why you do it, but the wins, I mean, it is for me, it's an outlet for my passion. I've always loved sport in general. I love playing it. I've loved following it. It doesn't take much for me to get hooked onto a sport. And Port Adelaide's done that for me, as Carlton's probably done it for you.
Yeah, and keep that white line fever to the lounge room.
That's it.
Thanks, Peter.
True.
If you want to learn more about SAHMRI and the researchers working to build a brighter, healthier future for you and your family, head to samhri.org.au.